Thank you. Thank you, Dr. Nicholas. Uh, Good afternoon, ladies and gentlemen, and it's always a pleasure to be back here again and speaking about a very important topic that have gained a lot of attention from the global policy makers and also from physicians and international pharmaceutical industry because of all the good reasons that has been cited by our previous speakers. So today I'm going to talk about hepatitis C, and my talk is not going to be necessarily focusing so much on the clinical part. Thank you. Thank you, David. My talk is not going to be on the clinical aspects as what has been discussed by our earlier speakers, but more focused around access to these medications, which as physicians, as researchers, and as patients, we need these medications for. To provide you an outline as to what I would speak on, it's important that before we start something, as we want at the level that we are in, we have to have certain segments of work that are done at an international level. So what have we achieved in those so far? So I will cite some of those just to refresh some of our memories. I will talk about the direct-acting antivirals, and Dr. Thira and David has spoken most about those in terms of the clinical aspects, but I will try to talk more on the regulatory status, and I will focus on the Indian generic medications, the licensed direct-acting antivirals, and we have been kind of following the growth and following the status of regulatory and pricing strategy for quite a long time now, since the time the DAAs have entered the market in Asia. I'll also talk about pricing, which you have, some of you must have seen in the past, but we have been updating this, and I've got updated information as on this last month, which is December of 2017. We have seen all the clinical advantages that has been cited, and also the need for HIV co-infection to be focused, both from the clinical point, the requirements, and also because it's so easy to actually manage at this point, in spite of whether or not you have a low immune or you don't have you have a mono infection. So it's more or less the same. So from that point, what we have to do to improve access, and at the end, I will provide you with a conclusion slide. In terms of achievements, policies plays a very important role in terms of shaping our national programs outside of the clinical practice at individual level. So we all remember that in May of 2010, the World Health Assembly approved the first viral hepatitis resolution. That was the first grounding work that was done by the World Health Assembly as member states to commit to saying that we all agree on addressing viral hepatitis as a public health issue. So that was May 2010. It was again reinforced in the World Health Assembly in 2014, again as a viral hepatitis resolution. So at the highest level of public health, which is the World Health Assembly, our governments, which includes all of us seated in this room, have agreed on, our governments have agreed on addressing viral hepatitis, not only hepatitis B, but other hepatitis C, but other viral hepatitis to be addressed as a public health issue. Following that, in April of 2014, the first WHO guidance on screening, care, and treatment of persons living with hepatitis C was launched. So this was the first initial launch by WHO on a guidance, and they have had, as you know, many guidances on many diseases, but for hepatitis C, this was the first guidance that was launched. Following that, WHO was also again mandated to develop plans by the World Health Assembly, because the countries would need plans and the countries would follow the region. So the WHO Western Pacific Regional Office, where Vietnam, Malaysia, they all fall in, Thailand falls in the CRO office. So in October 2015, the World Health Organization's Western Pacific Regional Office approved its first regional action plan. So in our region, this was the first regional plan to address viral hepatitis overall, not just hepatitis C, but viral hepatitis overall. Again, in 2016, April of 2016, the first guidance that was launched in 2014, WHO updated that guidance, and that was the guidance when we moved away from the first generation direct-acting antivirals, which we used to call as boceprevir and teleprevir. We moved away slowly from that and doing away with pegylated interferon too. In May of 2016, there was a very important document again which was adopted, and this is what is called as the Global Health Sector Strategy on Viral Hepatitis. These are the basis, these are the documents that our national governments follow as we address and start talking about viral hepatitis C in our region and in our countries. And then in April 2017, last year, the Southeast Asia Regional Office, which is based in New Delhi, where Thailand and India and Indonesia, Myanmar falls into, approved their regional action plan. So the regional action plans are in place. The countries are developing their own action plan based on this regional plan, which ultimately is talking about the global health sector strategy, which aims at eliminating viral hepatitis by 2030. So that's the basis that we are looking at, elimination of viral hepatitis by 2030. Right now, the WHO on guidance again on hepatitis C is being updated, and we're looking at moving on to pangenotypic regimens and not necessarily focusing on drugs which are subscribed or prescribed based on genotypes, but moving on to prescription drugs which are pangenotypic in nature, which has been discussed earlier. I will talk more on that later. In terms of medications, we have progressed a lot, and Ajantira talked about 90% plus, and those medications which are like almost curing 100% of the patients. In May of 2017, now I'm going to go down a little bit on the generics, and our first pangenotypic regimen, which was the sofosbuvir and velpatasvir, was approved by the US FDA in June of 2016. By not even a year, we had the first generics that was coming out licensed by Gilead. So in May 2017, we had the first pangenotypic regimen of sof and velpatasvir. January 28. So we have had this. I did not cite. I took out the ones which are older ones, like the generic sofosbuvir, generic sof, and the depasvir, generic daclatasvir. I have not cited those because those are older versions of the medications. I have slides where I have indicated, so you can have a look at the latest slides as to when those drugs in generic forms came out. Global Fund, the expert review panel, which is there in the Global Fund along with WHO, where experts constitutes assessing the quality of the medication, have already approved 4 generic versions of sofosbuvir, and this includes 1 from Egypt and 3 from India. So this 4 sofosbuvir is available now, approved, and quality is certain by the Global Fund and WHO. They call it as an ERP, expert review panel, and they've said that this drug functions as good as the innovator drugs. So those are there. Now, one important aspect when it comes to public health national programs is the WHO pre-qualification process. So WHO at Geneva level has a team which is called as the pre-qualification team, which assesses medications for HIV and other medications for other illnesses, and they check the quality, the manufacturing quality, the end product, the finished product, check the quality of those and certify that to say that this meets the quality standards that WHO expects, and national programs could use those medications for their own procurement. And a lot of HIV medication, mostly the first line and second line medications, have been approved by WHO PQ team for procurement under the Global Fund Purchase Program or national program. So we have now 2 generic versions of, so out of that 4, 2 have already been approved and 1 outside the PQ. 2 have been already approved by the WHO pre-qualification and have been pre-qualified. Out of that, again, I just wanted to touch a little bit because we always miss to talk about hepatitis B, that entecavir, TDF has always has been approved in the past, but for entecavir also now we have 2 formulations, 1.5 milligram and 1 milligram, and another is 1 milligram, which has already been approved by WHO, and that quality ascertaining mechanism has been in place. So in terms of the direct-acting antivirals, now some of you could have seen this slide in many in other conferences where I have spoken, or have seen in the last slide, but this is totally kind of updated. So we saw the first pan-genotypic regimen that we saw in our region. I'm focusing on the ones which WHO would likely have either recommended as a preferred regimen or will be coming up as a preferred regimen, and it's available at the moment in the region as kind of generic forms. We have from June of 2016 Epclusa, which was from Gilead. We have had Sovaldi, the Sofosbuvir from Gilead again. We have had Harvoni, Ledipasvir, and Sofosbuvir co-formulation. And we also have Daglinza, which is Daclatasvir from Bristol Myers Squibb. We have also seen the generic formulations of a generic Velpatasvir and Sofosbuvir, and these are licensed by Gilead. And in India, there are 11 companies which have been licensed by Gilead to manufacture the products which are within their product range. And Velpatasvir Sofosbuvir is one of them. We also have seen generic Sofosbuvir, and this has been in the market for quite a few years now. We have seen generic Sofosbuvir and Ledipasvir, and we also have seen generic Daclatasvir. I have just picked some of the pictures which are available on the internet, and not necessarily promoting or talking about any of the brands here, but it's just trying to show that these products are already available. But in terms of the availability of this medication or registration of this medication, where are these medications in a zero region? And most of you work in different clinics and settings. I'll be happy to stand corrected and seek your information in case if anything is inaccurate in my slides. So Bangladesh is a country which is a least developed country. Under World Trade Organization's rules, least developed countries are not supposed to provide patent on medications up until 2033. And that is that exemption which has been provided by the World Trade Organization that is being utilized by the Bangladeshi pharmaceutical industry to manufacture a different kind of DAAs and also other medications around HIV and other infectious diseases. In India, it is all coming out from the licensed manufacturers. Either it is by Gilead or by the Medicines Patent Pool. Through Medicines Patent Pool, the license provided by Bristol Myers Squibb. So we have had this, and if some of you were there, if you were there in the last session, you have seen there has been a great increase in terms of scope of this availability of this medication. So in most of the countries now, we have Sofosbuvir and Daclatasvir, at least in the countries where I have cited here, available. In Thailand, we have only the originator versions at the moment. The generic Sofosbuvir and Soflet has been filed for registration after Thailand was included in the licensed territory in August of 2017. And I have been told that the Sofosbuvir one has been approved now by the Thai FDA. I'm not sure if the marketing authorization is already there or not. But this is the scope as to where we are looking at. Almost quite a lot of countries have advanced in terms of availing these medications, and their FDAs doing better. Of course, the Olysio, which is Semipravir, which was talked about earlier, and Zapetir, which is Elbavir and Grizopravir. We don't have to remember those names. It's even really difficult to pronounce, and even for primary English language speakers, it's difficult to pronounce those names. So those drugs don't have generic formulation still, and those are not available in many of the countries where generic forms are not available. In the case of Wipro, Cambodia is the first country to accept a registration dossier and approve for Sofosbuvir and Velpatasvir. So they have that at this point. Outside of that, also others are increasing their scope in terms of availability of this medication. Vietnam has, and Indonesia has. I did not cite in Indonesia because they moved on. In the 2018 Symposium, I had that in the slide. They have something which is called as a special import quota. So this is a mechanism which is allowed. So Nepal allows it, Indonesia allows it, and also Vietnam allows it. They have different terminologies. In Indonesia, it is called a special assistance scheme. In Vietnam, it's called a special import quota. So the FDA of that country, for example, in Indonesia, it's called as BPOM, and in Vietnam, it's called as DAV. So they allow import of drugs prior to the formal registration. So they have been utilizing that to get these generics as and made it available at their major referral hospitals prior to their FDAs actually approving those medications. So this is an avenue which is available for you as physicians in large referral hospitals if you would like to receive a medication and it's pending, and you can check with your own FDAs if this is an avenue that is available in your country, and if you could utilize that as a part of your hospital. So Vietnam has been utilizing this, and they also have got tenofovir alafenamide now for treatment of hepatitis B, and importing that as a part of the special import license. So that is how some of the countries and referral hospitals functions prior to as and when as they wait for the formal approval. Now, so you have heard a lot about, you know, what do we call the license, the voluntary license that has been given to the Indian generics by this different innovator companies. So I wanted to give you a reality check as to where we are in terms of this drug registration. So Gilead has provided license to 11 Indian companies and another 3 companies outside of India as not for export but for production inside their own country. So including of Thailand and Malaysia, Belarus and Ukraine, last 4 countries to include in August. We have 105 countries which has been licensed by Gilead. By BMS, through the medicines patent pool for daclatasvir, we have 112 countries, to 112 countries that has been approved, that has been provided license for. Now, Sovaldi has been in developing countries. Gilead has been able to register Sovaldi in 27 countries. The generic companies from India have been able to do it in 32 countries. Now, there is an overlap in between this 27 and 32, but the Indian companies have really, if you remember last year, I think it was around 18 that the Indian companies have done. And in the past 1 year, they have been able to achieve 32 countries. I'll come to where these 32 countries are at some point in the later slides. Gilead has been able to do registration of Harvoni in 27 countries, and this includes Thailand. And Malaysia too, and our generic companies from India has been able to do in 25 countries. Again, there's a slight overlapping, but most the Indian companies have been really able to do a lot of work in Africa, where the innovator companies have not really ventured into in terms of making their products available. Generic daclatasvir is available in 18 countries, but it is not available in Thailand. At this point, but one point for Thai physicians and others to note is the license agreement allows Indian companies to register these medications, especially daclatasvir, where patents are not granted. This is the same for dolutegravir also. So there's an exclusion to say that if your country doesn't have an existing patent on these medications, the countries can actually get these drugs. Malaysia have progressed doing that. Thailand hasn't. Malaysia is now registering daclatasvir. They are not included in the license. But for Thailand, we haven't progressed onto getting the generic drugs, generic daclatasvir at this point. For Epclusa from Gilead, it has been in 4 countries so far, none in our settings. But the generic Epclusa is available as registered in 3 countries now, including, as I said, Cambodia and also in India. Let's look at the real scenario as to where we are. I took out purposely the parts which are from Africa, Eastern Europe, and Latin America. We have that information should any one of you require. But the Indian companies have been able to register this drug, sofosbuvir, in 10 countries. Thailand and Vietnam are still pending. Thailand, as I have been told, has been approved. I'm not sure if the marketing authorization is there. We can check that later. I would appreciate if some of you could check that information and share it to HIV-NAT or Thai Red Cross. And Vietnam, as I say, have been getting this product irrespective of the pending registration through the special import quota. In the case of Sof and Ledipasvir, but if you look at the African countries, look at, you know, Africa and Middle East, and they're doing much better compared to our FDAs. Of course, FDA have their own regulations, national regulations, and protection of the patients, and making sure that it's safe for use in the country. But in terms of the registration dossiers getting approved, Africa is doing much better. Same is the case in the case of Ledipasvir. We have 5 countries which has approved Ledipasvir and Sofosbuvir co-formulation, whereas in Africa it is 8 countries at this point. Again, Vietnam has been procuring it through the special import quota. In terms of Daclatasvir, 7 countries in Asia have approved, and 4 are ongoing registration dossier examination at their national regulatory level. If you look at the number of Sofosbuvir against 10, so we all as clinicians and researchers would agree that it's actually suboptimal to prescribe, except in the case of genotype 2, to prescribe Sofosbuvir alone with ribavirin-based therapy to the patients. But in the case of non-availability of medication, if we don't have Daclatasvir, for example, we don't have an option. So if we have 10 Sofosbuvir, we have only 7 where Daclatasvir is registered. So as countries which have already approved Sofosbuvir, and where countries which have large number of genotype 3, example Malaysia and also Thailand, we need Daclatasvir to come in as early as possible, and also to look at the generic options that are available there. We already have Daclinza here, innovator Daclatasvir in Thailand, but then you know, you will see why the importance of generics is there in terms when it comes to pricing. For Velpatasvir, we have again 4 countries. Again, Nepal and Vietnam are special import, and Mongolia and Myanmar, Sri Lanka, they're undergoing examination. Mongolia is a very good example where drug regulatories have exercised extreme fast-track process. The innovator Harvoni was approved in 7 working days. And they have a lot of genotype 1 and genotype 6. So 98% of Mongolia's population is that. So at that time, Velpatasvir was not available. So they exercised their own discretion of fast approving the innovator Sof and Ledipasvir, within approving it and making it available in the country within 7 working days. So as and when national regulator wants to do it, and Vietnam has similar. Vietnam has genotype 1 and 6, 98%. Of course, they're progressing on to looking at more pan-genotypic regimen and doing away with genotyping test altogether. But then that was an option that was available, and Mongolian FDA totally exercised that and approved Harmony within 7 working days. Now, in terms of price, and we have updated this as of December, and you would see that there has been a consistent price in terms of, and not much of a drop in the last 4 or 5 months. And Sofosbuvir now in India, private purchase. If any one of you goes to India, you can get it. If you go through the right channels, if you go to a pharmacy, you will be charged obviously quite high, because everybody is trying to make profits at certain points. But you can get Sofosbuvir for $55 a bottle. You can get Daclatasvir for 23 bottles. This is individual patient purchases. And $93 for a bottle of Sof and Ledipasvir. The Sof and Velpa, which was launched in May of 2017, have seen a considerable drop in the past 6 months, and you can get that for approximately $162 a bottle of Sof and Velpatasvir. So the case 1, which we talked about, that young lady which we're struggling for, probably could be treated with Sof and Ledipasvir for $270 because she was, I believe, non-cirrhotic. So that was one of the things. So, and then Sof DAC is around 234. And then Sof-Vel, you can get it at 486. This is individual private purchase in India. If you look at the government purchase, so our NHSO in Thailand is trying to negotiate all these drugs, and we have been sharing this information to different connections that we have at the government and civil society level. You can get Sof and Led for $61. Sofosbuvir for a bottle of $14, and Daclatasvir for a bottle of $12. This is government purchase price. And health is a state subject in India, and certain state governments out of the total Indian 34 or 35 states have started providing hepatitis C treatment to its citizens, and they are procuring SOF and DAC and SOF-lead. No SOF-well at this point, but SOF and DAC and SOF-lead is being procured by the Indian government. So they're literally treating every non-cirrhotic patient at $78 and for SOF-lead at $183 for a patient for 12 weeks. They follow SOF-DAC as a pangenotypic regimen unless a person is cirrhotic, and after if a person is cirrhotic, then they use they do genotyping and choose the regimen either SOF-DAC or SOF-lead based on the genotype after the genotyping, only on cirrhotic patients. If we look at now, so India is very cheap, but where are we in terms of, you know, other countries where we are from? So India, as I said, is on the right-hand side of your right-hand-most bar. But Indonesia or Vietnam or Cambodia or Myanmar, which are not necessarily doing much better, the patients are not economically much more sound compared to the Indian patients, are paying way much more than what the Indian patients are paying. So there is also a justification from our generic colleagues to say that there are certain, you know, things which are out of their control, and pricing of these medications depends on the distributors who imports this medication on their countries. But we are seeing a wide variance of pricing in terms of availability of these medications. So Vietnam, if for 600, I'm sure Vietnamese colleagues are here, if you're getting 609 bottles, and we heard there was some negotiations, you might be paying lesser for the innovator product than actual generic product. But Mongolia set an example to say that we register the innovator, we register all the generics as much as possible so that there is availability for the patients and there is pricing competition that happens, which allows patients to pay lesser and the governments to reimburse lesser. So what needs to happen if we are to improve access? We have to find the patients. Only 25% of patients globally are diagnosed. So we have 71 million people altogether, viremic. We only know out of that 25%, and we have to find these patients to link them to care. To find these patients, we really have to build the awareness of the infection among people, and this is indeed a curable infection, and you don't have to go through lengthy treatment and also do away with you know, the side effects that PEC interferon used to have, and don't have to be scared anymore. So that awareness has to be built among patients, and finding those patients would ultimately become a little more easier, if not altogether possible. We have to control new infections. In 2015, WHO said that we treated 1 million people globally, and out of that 800,000 people came out from the Egyptian National Viral Hepatitis Program. And out of that, while we were treating 1 million people, we had 1.75 million new infections. So we have nowhere control the infections which are occurring newly as we diagnose and treat more people. We have to control this new infection through various mechanisms, I'm sure, which will be discussed partly in injection safety and harm reduction approaches among people who inject drugs, those approaches which are their occupational hazards to be addressed among medical professionals. So we have to control new infections if we are to treat this. WHO now says that in 2015 and 16 we have treated 3 million people, but we're getting still 1.75 new million infections. And we all, as physicians, as researchers, as clinicians, practitioners, civil society groups, have a responsibility to contribute in ensuring that we pass on the message as much as possible, not only to treat the patients, but also to get new patients and control new infections. We have to register these drugs as early as possible. The time taken by RFDAs, irrespective of the data that is required and the processes that are being undertaken, is quite long and tedious. And we have to register, and Mongolia, as I said, is an example of doing that. We have to make these drugs more affordable. If we are getting at $78, in Egypt it is $84 for a treatment course for 84 for the 84 tablets of SOF and daclatasphere. So if we're getting at $70, $80, there would definitely be you know, interest among procurement. This one, India and examples are good examples. We have to expand the tool of treating physicians. As Treat Asia, we have been training a lot of physicians. Recently, we trained 36 physicians in collaboration with WHO and 2 viral hepatitis collaborating centers from 9 countries in the region, excluding Malaysia. Malaysia did not nominate anybody, but others, Philippines, Vietnam, all Thailand, we trained around 36 physicians, both on hepatitis B and hepatitis C. And try to reach really the non-specialist out of gastro and hepatology care. So policies are in place in conclusion to support our work, to place programs at the national level in place. But we need better leadership. We have committed in World Health Assembly, but at national level, our responses are pretty slow. We have to do fast track of drug registrations, which we have been talking to wherever we go. We meet DAV, we meet BPOM, we meet Thai FDA. We have been passing this information that what is it that you really need. Your patients are waiting there, your physicians are waiting there, your national health security officers or your public health programs are waiting for this medications. You need this. Please pass on this information as you go and meet other people. Yes, they have to go through their process, but we can do better. There is a growing but still limited availability of these generic medications, and again we have to have a broader prescriber pool. With the help of the hepatology doctors and gastro doctors, we need to expand our care to reach the other patients who cannot reach the specialist. Thank you very much, and I'll be happy to take questions.